Dear friends, first of all, I would like to thank the ISRS to give me the opportunity to talk about high-performance IOLsPost corneal refractive surgery at the Muscat International Ophthalmology Conference. These are my financial disclosures. I'm ERIK Mertens and I'm practicing in Antwerp, Belgium, mostly cataract and refractive surgery. Now, there are an increasing numbers of post-corneal based vision correction patients and they seek lens replacement surgery. But we bump into a lot of challenges in these eyes, of course. First of all, ocular surface disease must be taken care of. What is the quality of the cornea? We will look at the higher order aberrations here. How can we accurately calculate the perfect IOL, dioptrical power, and last but not least, which IOL we will choose in which case. When we look at the ocular surface, it's very important that we look at it and we deal and treat it before we do any kind of diagnostics and of course surgery, because otherwise the patient will blame you, the surgeon, that the ocular surface is not good. They don't know that it's the ocular surface, they only say that the visual quality is not good enough or they have fluctuations in vision. That's why this is very important. So this can lead to, as I told you, inaccurate pre-surgical measurements, to errors in the calculation of the IOL and consequently refractive surprises. Visual quality can be reduced and the vision can fluctuate during the day. It can give surgical impaired outcomes and it can create new ocular surface disease symptoms, or it can. What about the preoperative evaluation? We're specifically looking for irregular stigmatism, unacceptable higher order aberrations, angles kappa and alpha. How do we do it? We look at our topography. Epithelial thickness map gives us valuable, very valuable information, and we also measure higher order aberrations. First, the topography map. This is an example of the MS39, and we specifically look here how regular is it in the pupillary region. In this example, it is very regular, so this can be a good candidate for high-performance IOL implantation post-corneal base. This is not a good example, and when you look here, you can see that in this region there is already a 4 diopter difference from this side to the pupil to this side to the pupil. So of course this is not a good candidate. Maybe for a pinhole IOL, but more about this lens later. This is the epithelial thickness map. In this case, you can appreciate this is a 4-incision RK patient. And this is of course normal that you have epithelial hyperproliferation in the incision sites. But this is very interesting to look at these maps before touching any eye in this case. Another example, this is with the eye trace. Here again, a lot of, in the pupillary zone, the changes are enormous. And when we look at the coma here, of course, we find a huge coma, which is an absolute red flag for implantation of high-performance IOL based on trifocal disease. This is another example, and when you can appreciate here that the total higher order aberration is 0.38, but coma and spherical aberration is pretty low. Most of it is a trefoil, which is it's more peripherally localized to trefoil higher order aberrations, and we don't take this into account to implant high-performance IOL in this case. So for me, this is a good case. Now, when looking further, what is the angle kappa and what is the angle alpha? Here's a very nice example. This is thanks to Uday Devkan, which I borrowed this image from, but it's a very nice explanation. So the optical center, this is the green dot, this is the center of the limbus. It's also actually the center of the optical system. Then, of course, the pupillary center is the center of the pupil, makes sense. And then you have the visual axis. And the angle kappa is the distance between visual axis and pupillary center. And then let's go to angle alpha, which is the distance between here the visual axis and the optical center. Now, what about these two things? There is a lot going on. Lots of people talk about angle kappa and angle alpha, but actually there was a very nice talk of Stephen Schellhorn a couple of years ago in the ACOS Aspen meeting, where he compared more than 10,000 eyes, and he found out that actually angle kappa is not a predictive factor in the satisfaction or the refractive outcomes in these cases. So for me, I do not look into the angle kappa anymore. I look at the angle alpha. And what are my preferences? When the angle alpha is less than 0.3 millimeters, for me this is a green flag. When it is between 0.3 and 0.5 millimeters, it's a yellow flag, meaning that there are other yellow flags. I will not go for implantation of high-performance IOLs. And definitely above 0.5 millimeters, it's from straightforward, it's a red flag, and we need to look for other solutions for this. Now, what about the intraocular lens power calculation? You have a very nice online calculator by IOLsPost, and you can put in all the numbers here, and then you can click calculate, which gives you a number for the IOL to implant. Another very good is the Barrett TrueCare calculator post-refractive surgery. But I used to use them many years ago, but I switched now to the total corneal power calculation, the TCP, of the Evanta OptiView OCT, which is based on the OCT of the cornea, a measurement of the net power of the cornea and the anterior and the posterior surface of the cornea, and on the epithelial thickness map. It gives 3 measurements and it calculates the average. The best 3 measurements are kept and in Excel file, and then you can get here the optical power to implant when the correct A constant is put into these Excel files. Also a very good tool is the ray tracing technology of the MS39. And it gives you the power to implant. For instance, in this eye we implanted the 18 diopter, and the refraction postoperatively was -1/4 of a diopter. For me, these two are now the predominant calculation methods post refractive surgery based on. What about the IOL choice? When the cornea had previous myopia, which means that there was probably induction of positive spherical aberration, choose a lens, of course, with a negative spherical aberration. Most of our trifocal IOLs and high-performance IOLs do have some negative spherical aberration. In this case, we have the fine vision from BVI to be implanted. Much harder cases are the previous hyperopia cases, because the centration is very crucial in this one. For me, the choices are the light adjustable lens. You can implant them and then induce some spherical aberration, positive spherical aberration, in these cases to counteract the negative spherical aberration on the cornea. Or when the centration is very good, you can go for a pinhole IOL, like this is an example. These are produced by Merker and by AcuFocus. And when you have irregular corneas, you only can have one choice, which is the pinhole IOL. So in conclusion, you have to be aware that there's a high demand of these patients. There are more and more patients who come in the age they need, they want presbyopia correction. And of course, refractive lens exchange is one of these options in these patients. So the demand is high. These patients are eager to be free of glasses because 20 or 30 years ago, they chose RK, PRK, or LASIK, or even SMILE in more recent days. So they're eager to become free of glasses. And of course, remember, one size doesn't fit all, so we need to customize for each eye individually. Very much for your kind attention.